Thank you. Good evening, all our members of Maharashtra Ophthalmological Society, especially all our young stars and the postgraduates and the residents from all over the state, and those of you who are also joining us from across India. We all know that all of you who are the current residents are the future of Indian ophthalmology. And of
All
course,
of you who are
not
also
only
joining us
in
from
terms of
across
gaining
India.
knowledge for
We
only
all know
your
that all of you
exams,
who
but
are
also
the
gaining
current
knowledge for
residents
your
are the
further
future of Indian
prospects
ophthalmology.
of your practice and let's say increasing your awareness about different specialities of ophthalmology in general. MOS has started this initiative this year where 1 month is dedicated to one specialty. And after dedicating the month to cornea last month, uh, this month is going to be dedicated to something that probably most of you are not really well versed with, because the ocular surface department is not really functional in majority of the eye hospitals. But this month will give you a good bird's eye view about what is important not only for your exams but also for your basics in ophthalmology. So here we have our webinar for postgraduates today and the residents on the ocular surface. We are going to have series of two webinars this month, and today is the first of the series. From MOS, as the chairman of the scientific committee, I welcome all of you, and I also welcome our esteemed panelist, our national faculty, Dr. Bhaskar Srinivasan from Shankar and Dr. Swapnil Bhalekar, who is joining us as a part of the MOS faculty, both of whom are doing outstanding work in ocular surface and has been great educators in the same. We also welcome today's mentors, the residents, and all the postgraduate teachers who have helped to shape the program for today. We especially thank Dr. Sumit Lahane for coordinating this residence program throughout the year, who has taken a lot of efforts in jotting down the nitty gritties of such programs. So, before we go further, now I would like to welcome our president, Dr. Santosh Agarwal, sir, who himself is a very dynamic entry as well as the retinal specialist, a alumnus of prestigious Shankar an extremely dynamic president that we all have for our MOS and a guiding light for us. So I would like to now request Dr. Agarwal sir, please to deliver his welcome address for today's webinar. Over to you, sir.
Thank you, Vardhaman, for your kind words. Respected seniors, teachers, my dear friends, postgraduates, greetings and good evening to one and all. I welcome you all to this unique webinar. We would tonight navigate through ocular surface diseases, wherein PGs would present the cases and subsequently they will face the Viva questions posed by their mentors, followed by the panel discussion. I express my gratitude to all the experts, panelists, moderator, scientific committee of MOS, and the audience for sparing their valuable time for this webinar. I am sure we all will be enlightened with the intricacies and nuances of these diseases. I thank Dr. Sumit, Dr. Vardhaman, Aditi, and Scientific Committee of MOS for curating such a beautiful webinar for PGs. I also request the PGs to please attend the webinar in large numbers and also put their queries in the chat box or send to Dr. Sumit Lahane to make it more interactive. I also seek your valuable feedback on these webinars. These are also available on MOS website as well as on YouTube channel. So today's quote is, if you compete with others, you become bitter. If you compete with yourself, you become better. So don't compete with anybody else, compete with yourself. That's the quote, today's quote. So with this, I will finish my talk. Thanks for your patient listening, and over to Vardhaman again. Thank you.
Thank you so much, sir. I think very well said. And I'm sure that our postgraduates will definitely try their best to emulate all the teachings that you have shared and the quotes as well. Now, I would like to welcome Dr. Sumit Lahane, who has been the chief coordinator for all these postgraduate programs throughout the year. And again, we would like to thank you, Sumit, for all your hard work. And over to you to continue the further proceedings. Thank you.
Thank you so much, sir. Good evening, everyone. So we have yet another episode of MOS postgraduate teaching, and I thank MOS, Santosh sir, Atul sir, and Vardhaman sir, Aditi ma'am, for giving us this platform via MOS to include all the medical colleges for this postgraduate teaching. So today we have a specialty of ocular surface, and we have two colleges here today participating with us. And, we have Dr. Pranali and Dr. Piyush from NKP Save Medical College Nagpur and GMC Akola. Thank you, both of them. They are the real heroes for today who took out time from their busy residency and prepared on such a short notice. We have their mentors with us, Dr. Guru Dasani sir. Sir is a professor at GMC Akola, and he is always a keen PG teacher, and he just agrees on everything we ask him for MOS or any program. Thank you, sir, for being there. We have Dr. Ajay Kulkarni, sir. Sir is a cornea specialist. I must say he must be the first cornea specialist of whole Vidarbha region. And sir is also honorary faculty at NKP Survey. Thank you, sir, for agreeing to be here. And our mentors are Dr. Swapnil Bhalekar, sir. Sir is a alumnus of LVP. He did his cornea fellowship from there and is working at Shirur, and he's well known for his work in ocular surface. Thank you, Swapnil sir, for being here. And we have Dr. Bhaskar Srinivasan sir. Sir does not need any introduction. He is authority in ocular surface and working at Shankar Netralaya. And the best thing about him that I ask him for any program and he is ready on a single message or single call. He's always there for us. Thank you, Srinivasan sir, for being here. And Dr. Ganesh Gaikwad is my colleague. He is a cornea specialist working in Nasik. He did his cornea fellowship from Arvind Netralaya. And today he is moderator to all of us and he will be moderating the whole session. So without wasting much time, I will request Dr. Piyush to please share his presentation and let's begin. Dr. Piyush, can you please share the presentation?
Yes.
Yeah. Please make it full screen. Yeah, go ahead. Yeah.
I'll be presenting a case on cornea today. An 8 years old male child, a resident of Nagpur, was brought by his parents with complaints of loss of vision, pain, and watering in right eye since 3 days. He was apparently all right 3 days back when he developed sudden loss of vision associated with pain in the right eye. There is history of trauma to right eye due to tuna entry 3 days back, for which patient was taken to a local hospital where eye wash was given and patient was started on topical drops. The drops were eye ointment erythromycin 0.5% 4 times a day and carboxymethyl cellulose eye drops 0.5% 6 times a day. There is history of redness and watering in right eye since 3 days. There is no history of use of specs, clear or colored halos or headache. There is no history of previous ocular trauma, ocular surgery, food or drug allergy, or any systemic illness. Personal history and family history is not significant. On general examination, patient is conscious and oriented and vitals are stable. The systemic examination is within normal limits. On ophthalmic examination, the head posture is normal and there is no facial asymmetry and eyes appear orthophory. I would like to describe right eye first. His best corrected visual acuity is counting finger 2 meter with PR accurate. The leads are edematous. The conjunctiva, there is 360-degree limbal ischemia and no deposits of lime were seen. On the cornea, there is total epithelial defect with edematous cornea and deposits of lime were seen. Anterior chamber, iris, pupil lens could not be assessed and there was no view of fundus. In the left eye, vision was 6 by 6 and anterior segment leads, conjunctiva, cornea, anterior chamber, iris, pupil lens were normal and fundus was normal with CDR of 0.3:1. So my diagnosis is right eye grade 4 chemical injury with Dwas classification with total epithelial defect and left eye is within normal. Thank you.
That was a very nice presentation, Piyush. For Piyush, as there is a cross questioning, Kulkarni sir, any questions from you for him?
No, Dr. Bhavish, let him ask whatever he wants to ask.
Okay.
Basically, my questions will be basically on the classification which he uses because there are a lot of classifications available. But we have to choose the one which actually helps us in treatment of the patients and prognosticating the outcome. Uh, there are certain points which we would highlight after the discussions. So let Dr. Bhavesh ask if he has anything to ask.
Gurudasani sir, questions from you? Sir, you are muted. Gurudasani sir, you are muted.
Hello, Piyush.
Yes.
So we will talk about the management of the patients with chemical injury. So what is the first and foremost step in management of this chemical injury?
Sir, the chemical injury is an true ophthalmic emergency. Firstly, we have to give the eye wash, thorough eye wash. The preferred solution is balanced salt solution, or any sterile liquid can be used, that is normal saline or ringer lactate. It should be given for minimum of 30 minutes, and pH should be examined first, and wash should be given till the pH is neutralized.
And which classification have you used to grade this chemical
Sir, I
injury?
have used Duas classification.
So do you know Roper Hall classification?
Yes, sir.
So what is the difference between these two?
Sir, Roper Hall classification classifies the chemical injuries in 4 grades, and Duas is in more detail, and it classifies in 6 grades. In the Roper Hall, the involvement of cornea and limbus is considered. In grade 1, there is corneal epidefect, defect, and there is no limbal involvement, and prognosis is good. In grade 2, the corneal involvement is there, the corneal haze is there, but details of the iris can be seen, and the limbal involvement is less than 1/3. In grade 3 of the Roper Hall, uh, the cornea is hazy and iris details cannot be seen, and limbal involvement is 1/3 to 1/2. And in grade 4 chemical injuries, there is total limbal involvement and cornea is opaque, and iris details and pupil details are obscured in Roper Hall. In the Duas classification, it is in detail and it grades in six stages. The grade 1 is uh, there is no limbal involvement, and conjunctiva, there is no involvement of conjunctiva, with it has a very good prognosis. In grade 2, there is limbal involvement from 0 to 3 clock hours, and conjunctival involvement is 0 to 30%. And in grade 3, the limbal involvement is 3 to 6 lockout's, and conjunctival involvement is 30 to 50%. In grade 4, the limbal involvement is 6 to 9 clockers, and conjunctival involvement is uh, 50 to 75%. And in grade 5, the prognosis is very poor. The limbal involvement is 9 to 12 with conjunctival involvement of 75 to 100. And in grade 6, there is total limbal involvement and total conjunctival involvement. And prognosis is very poor in grade 6.
What is the significance of this grading?
Sir, these gradings gives the prognostic value. We can know the prognosis by if we divide it correctly.
So how is the prognosis of this patient according to you?
Sir, since it is a very severe chemical injury, it falls in grade 6 category. The prognosis is very poor.
And according to Roper Hall, how will you grade this injury?
Sir, according to Roper, it is grade 4 injury.
Okay. So how
We have okay.
so what are the signs of this limbal ischemia or limbal stem cell loss? How will you clinically know this?
Uh, Sir, if the limbus is involved, the conjunctiva will appear pale. There will be no uh, congestion.
Um,
And
okay.
how
I
will you
have,
treat
we
this
have quite,
patient?
Sorry, sir.
How will you treat this patient?
So firstly, I will give the eye wash as I described. Then I will start the patient on the medical treatment. That is, I will start with antibiotics to avoid the infection. The preferred is eye ointment erythromycin, uh, 4 times a day. I will start on lubricating eye drops also, and cycloplegics for the plain pain. That is eye drop atropine 1%, 3 times a day. And I will also start this patient on steroids. That is eye drop for 1%, 1 hourly. Then I will give patient tablet vitamin C supplementation, and tablet doxy also 100 mg twice daily.
Okay, now
Okay.
question for finally, at what stage we go for a amniotic membrane graft? Also, Kulkarni sir also.
Yeah, this is very important to know when to intervene surgically. Before we actually go on to answer your question, uh, all these classifications, they talk about involvement of corneal surface, the limbus, and the bulbar conjunctiva. But a severe and ongoing damage does happen uh, because of things happening in the fornix, the posterior lid margin, and the tarsal conjunctiva. We should not basically, forget about these areas of the ocular surface. And grade 1, grade 2, obviously we know that this can be managed very well with medical line of treatment. 3 and 4, yes, there is a role of amniotic membrane transplantation, but it all depends on at what time of after the injury you are seeing the patient. Somebody who sees who's the first contact physician, he is in the best position to grade it because the clinical picture changes over a period of 2 to 3 days. By the time the child presents to you after 3 days, the signs will be different. The areas which looked ischemic on day one, you might see some blood vessels coming in and the epithelium starts moving. So this grading system, it all depends on at what stage you are looking at a patient after the child has been injured. So for grade 4 or 5 or 6, according to Duva's classification, this is a case wherein I would definitely consider amniotic membrane transplant. And most important error which is seen in the management of chemical injuries in immediate, early, or reparative phase is to failure to control the inflammation. Many times you will see that the patient presents and nobody gives steroids. So this concept of not giving steroids in the presence of corneal epithelial defect is so deeply rooted that we have been struggling to pass on this message, but you still don't see patients being given a topical steroid because that can severely, that can control the damage in the future. So this case, I certainly would consider amniotic membrane.
I have a question for Bhaskar sir. When we should taper steroids? Because starting steroid is okay, but when to reduce the frequency of steroid?
Yeah. So before I come to the tapering of steroids, a couple of points. First and foremost, a child with a Chuna injury should have been taken up for examination under anesthesia. You will find pockets of lime stuck in the superior fornix.
Yeah.
Start giving a wash will not wash away the lime particles. So the child should have had an examination under anesthesia. Any child with a Chuna, you will do an examination under anesthesia. Point one. Point two, I would have liked to see stained images of the cornea, because when you said there was no conjunctival defect, unlikely. I would expect a superior conjunctival defect in that picture in 3 days or 4 days time that the patient comes, especially with such a large lime plaque sitting on the cornea as such. When you have an active lime particle sitting, no amount of topical steroids, systemic steroids is going to control the inflammation unless you remove the source of inflammation out. So it was important to have taken up the patient under anesthesia, evert the lid, remove any Chuna stuck in the conjunctiva. And if there is a lime plaque in the cornea, you might actually have to do a lamellar keratoplasty also, or you can use EDTA to try to chelate the superficial particles as much. But if it is deeper, you might actually have to remove that, because as long as it is there, it is going to be a source of inflammation till it gets converted to calcium carbonate at a later phase of time. Now, if you're seeing a patient with a lime plaque sitting in the eye after 6 months and the eye is quiet, you don't have to go and dig into it and remove it. But in the acute stage at 3 days, 4 days post-injury, if you're seeing a lime plaque, you might want to remove it, because that is one impediment for any treatment that you would do as far as this child is concerned. So this child should have had an examination, removed of whatever is the fornical lime deposit, removed the calcium plaque, and then the amniotic, because when you have such a large defect, you know it is not going to heal by itself, or even if it heals, it's going to take a long time for the epithelium to heal. And if it takes a long time for the epithelium to heal, the underlying cornea will end up either getting scarred or it will end up with a melt or a perforation, both of which will make your prognosis poorer than what you started off with. Next important thing which we tend to miss is IOP. You will not be able to measure it with AT or tonopen. You can do a tonopen in the under anesthesia, but if your lime plaque is sitting, you might still get an erroneous value. You could try a Sheward's or a finger tension, at least to know that the pressure is high, moderate, or low, because your decision on starting anti-glaucoma medications is important to protect the optic nerve. 3, not in this particular case because this is a lime plaque, but if it's like an acid injury, you will look at a changing scenario with respect to entropion or ectropion as the skin contracts. Again, exposure is something that is not looked at when we look at a burn. We just look at the corneal epithelial defect and we say, okay, amniotic. Amniotic is one part of the treatment, but you have to look at the holistic picture. Your aim of treatment in this case is to remove the offending agent first, initiate treatment for the inflammation next, facilitate epithelialization third, get your intraocular pressure under control fourth, and manage any sequelae which the patient presents with. Like Dr. Kulkarni said, it is important for you to grade it at the first time when the patient presents. If the patient comes to you after 2 weeks and it is still grade 4 or grade 5, it actually means the patient started off with grade 6. In 2 weeks time, what you're looking at is a slightly better picture as compared to what the patient actually suffered with. So the timeline of when you are seeing the patient as a documentation is also important when you put everything in line. Next important thing, whether it is unilateral or bilateral. If it is bilateral, you are going to be more aggressive in terms of at least salvaging one of the two eyes. If it is unilateral, also you will be aggressive because you have an autogenic slit subsequently to address his visual requirements. So categorizing the patient with respect to unilaterality, bilaterality, categorizing it with respect to time of presentation, looking at all the 4 factors which we have published as I's and E's in acute chemical injury. It's available in Ocular Surface journal. If somebody wants, I can share the PDF, is important. We've also published something on the way that we look at in terms of clinical practice as EPICS. You can read it up more from your understanding point of view. From the exam point of view, some of the things are more newer. People might have some reservations about using it as far as your theory paper is concerned. But in terms of understanding a management, reading that paper would make your thought process a lot more clear. Coming to topical steroids, we are always worried that after 10 days, giving topical steroids will cause a corneal melt because collagenolisis happens. The cornea is going to melt if there is no epithelium, whether you give topical steroids or not. So your aim is to get the epithelium on. So if it's a milder defect, not as bad as what you saw, and you have put a bandage lens and you have started the topical treatment, by a week, if you see there is no response, the defect is still there, that tells you go ahead and do an amniotic because you still need the steroid to control the inflammation. With the amniotic there, the possibility of the metalloproteases reaching the stroma to cause a stromal melt is reduced. You add on vitamin C, doxycycline for your pro-collagen features as such. But your primary aim is remove the offending agent, get the epithelium to heal as quick as possible, and remove any offending agent. With such a large lime plaque, with such a large extensive defect, we would probably have thought of doing an allogenic slit along with the amniotic membrane to facilitate the epithelialization. But all that will only work if we are able to remove the lime plaque from the cornea.
Swapnil sir, is there any role of autologous serum in these cases?
See, before that, one addition I would like to make what Dr. Bhaskar had said, very important points actually he has said. One is that he said that, that lime cannot be washed completely. So you have to take patient under GA or whatever possible. And then you have to explore the Chuna flex. One more important thing in that is sometimes you are able to remove the Chuna flex which are lying in the fornix, but sometimes they're embedded into the conjunctiva. And you have to cut that conjunctiva away and take that Chuna out. Most of the time, people ask me that, if you cut the conjunctiva, it will form symblepharon. Doesn't matter. Symblepharon is not a bad thing. You can take this as a message. It is not a bad thing. As long as the surface is healing, We can deal with Simplifron later on. But for that, moment, you have to get rid of that tuna fleck because it is going to cause further damage onto the ocular surface. Second, Dr. Piyush, the main difference between Roper Hall classification and Dua's classification is the use of term ischemia, and Dua has used classification has used the term involvement. So there is a huge difference in these two terms. That ischemia itself says that it is a permanent damage. So there has been study in LVP which is done, and Dr. Sayan has tried to study if the renowned ocular surface specialists who regularly see these patients are able to identify whether this is ischemia or just fluorescent staining. So there is no reliability. So you cannot just look at the defect and say that this is ischemia, and that's why the term involvement came. The involvement he defined in a way that if there is limbal staining, you can say that it is limbal involvement. If there is conjunctival staining, you can say that it is conjunctival involvement. So in that classification, the importance was given to the term involvement because you have to grade patient every 2 to 3 days, and if it keeps on improving, then you can keep on regrading it. If the grading is improving, then you can decide on the medical management versus surgical management. If it is not improving, you can obviously go for surgical management. That is one point. And also, I think you also have to use because you have mentioned Dua's classification, but you have mentioned the term as limbal ischemia, number one. And number two, conjunctival involvement has to be mentioned very specifically how much is the defect, because that is also given a lot of importance into the classification, because conjunctiva itself has some healing power. It has stem cells in the fornix which makes surface heal. So both these things I think should be taken into consideration. About your question, autologous serum, yes, they would help, but they are not the mainstay of treatment in acute chemical injury as such. Acute chemical injury mainstay of treatment remains steroids, debridement, and I'll say amniotic membrane added with tarsorrhaphy. Tarsorrhaphy is a wonderful technique which will protect the surface, make it heal properly. So whenever you are doing amniotic membrane grafting, just adding the tarsorrhaphy helps a lot. It goes long way in saving the surface.
If I could just add with respect to the grading. So when you are looking at Dua's grading, so the grading is given based on the limbal involvement.
Yeah.
Grade 1, 2, 3, 4, 5, 6 is based on the limbal involvement. When you look at the conjunctival involvement, it actually follows that, saying 50 to 70 or 70. But you might have a discrepancy. You might have 30% of conjunctival involvement and 12 clock hours of limbal involvement. So that is why it is preferable when you are documenting it to document the extent of conjunctival involvement also. So it will be like grade 6 Duas, 30% of conjunctiva and 100% of cornea. That tells you, because if your conjunctiva is less involved, there is a source of epithelium to cover the surface. In the acute chemical injury, what you want is the epithelium has to grow ASAP. So if the conjunctiva is also denuded, the epithelium has to come from the fornix. If your conjunctiva is still intact in a reasonable area, you will get a conjunctivalization of the surface, which is not bad as long as the cornea is protected. So that was the main basic difference between the Rupert Hall and the Duas, because what Dua tried to say is all grade 4 Rupert Halls don't behave similarly because of different involvement of the conjunctiva and the cornea. We now know similar is the case even with Duas. All Duas 4, 5, 6 do not behave in a similar manner because people don't talk about pressure, people don't talk about exposure. Those are changes that happen over a period of time, and you have to be aware of it and keep on looking. So you need to make a checklist of things that you will look at. Okay, look at the lids, look at the epithelial defect on the conjunctiva, cornea, look at the pressure, look at the exposure. These are the four main things that you will always follow in these patients to make sure that you don't miss any of these parameters.
One more thing, Dr. Bhaskar, just to clear, make it more clear things. When we say that the aim is to epithelize the surface, for most of the people, it is like achieving the clear cornea or achieving the having the corneal epithelium in place. So please don't confuse this. Epithelium is any epithelium is okay. It is corneal epithelium, fine, good. But even if it is conjunctivalization of the cornea, please don't worry. That's an excellent outcome which can be dealt with later on with limbal stem cell transplantation. So the end point of any acute chemical injury, whether it has responded well or not, it could be corneal epithelium, healing with corneal epithelium. It could be healing with conjunctival epithelium. Both endpoints are good endpoints. No need to worry about it. Many times, we say that surgeons calling and they say that, sir, surface healed, but it's all vascularized. So that's okay. Conjunctivalization, it's a stable epithelium. Surface has healed with conjunctivalization, that can be dealt with. So that's the message.
What you don't want is a perforation.
Exactly.
That changes you. So if you are having a thinning and it is progressing and nothing is working out, you don't have the option of an amniotic, then maybe even a glue BCL, tarsorrhaphy to tectonically stabilize the globe at that point of time. If your globe is intact, you can always fight the battle subsequently. Especially in a one-eyed individual, you always have the option of utilizing the limbus, utilizing the conjunctiva from the other eye to form the surface and give the patient visual rehabilitation subsequently.
So one question here, Bhaskar sir, and to everyone. Sir, you said that allogenic slet you will do in such cases, especially grade 6. We have heard lot of lectures that you recommend in this injury. So can you tell what is the advantage? Secondly, one practical question, sir. It becomes very difficult to get the fresh allogenic stem cells in lot of area. Like Swapnil sir must be facing the same issues, but we can get the older tissues where the cornea is not utilized as such. We can get stem cells of limbal stem cells from those tissues. So is it okay to use that in such acute cases? And secondly, what is the role of tenonplasty in such cases, either acute or chronic? Where will you use this tool? In what are the actual indications for the same, sir?
So I'll just finish the tenonplasty part first, because that actually comes before we talk about the alloslet as such. So again, scleral ischemia is a component which is not mentioned in any classification at this point of time. So when you look at the picture initially, there's a lot of chemosis, so you really do not know whether the episcleral vessels are intact or not. So you might actually initially feel that there's an area of no episcleral vessels because the conjunctival defect is there. The underlying fibrovascular core looks ischemic, but over a period of time it will come. The best way would be when you are actually doing a surgery, if you nick that area, you would ideally expect a bleed if there is a vascularity. If there is no bleed, then you know that area is ischemic. You will need to go try to advance tenons from a vascular area to get it closer to the limbus, which was first explained by Rime in 1997. So if there is focal area where there is absence of episcleral vasculature to the sclera, then no amount of epithelium is going to heal over an absolutely avascular structure. So you will always end up having a melt and a defect. So to avoid that, you would mobilize tenons from the periphery. It could be even deeper down towards the fornix. Separate the vascular tenons from the overlying conjunctiva and the underlying sclera. Make relaxing cuts. Mobilize it to the front and suture it close to the limbus with the vicryl suture. So now you have a vascular bed, and then you can put an amniotic for the conjunctival epithelium to grow in. So if you have a diffuse ischemia, definitely you would have to do a scleral tenonplasty. If it's a focal ischemia, you might probably get away if it is within 2 to 3 clock hours of ischemia, because the surrounding will heal. But that patch will actually be the last to heal till the vessels gradually creep in from the adjacent area. And if you are anyway taking the patient up into surgery, you can actually, it's just another 5 minutes of your procedure to mobilize the vascular tenons and securing it. Now, the most important thing what we need to understand is, like I said, for the surface to heal, you either need a corneal epithelium or you need a conjunctival epithelium. So if your defect is less than grade 3 Rupert Halls, you have sufficient corneal epithelial cells, sufficient corneal limbal cells. The epithelium will migrate and cover. In 2 weeks or 3 weeks, surface is epithelium. If it's a grade 4 or a 5, but your conjunctiva is still intact, conjunctiva is only 30% involved. It's not involved till the fornix. You will expect the remaining conjunctival cells to kind of creep in, and maybe instead of 2 weeks, it will probably heal by about a 4-week period. Now, it is important for us to know is the longer the cornea remains denuded of epithelium, the tendency for it to scar, the tendency for it to melt, and for you to end up with a perforation becomes higher. If you end up with a scar, then your subsequent visual rehabilitation will need a lamellar keratoplasty subsequently. So what you want is, you want the epithelium to grow on the surface as fast as possible. Now, if you have almost a fornix to fornix denuded conjunctival epithelium, and you have a total corneal epithelium defect, there is no epithelium to grow. The epithelium has to come from the tarsal conjunctiva to start going till the fornix and then come across the bulbar area and reach the cornea. So your cornea is going to be the last epithelialized. And we used to just do amniotic membranes with tenonplasty for these patients between 2005 when I joined Ascent till almost 2015 or 16. And every time we had to do multiple amniotics to get the epithelium to heal finally, because it's not that doing one amniotic and the epithelium will heal. Epithelium will dissolve in a week's time. You will have to redo it, or you have to do a tarsorrhaphy. Then all the fornices constrict, the lid sticks to it, and then it becomes more heroic when you have to reconstruct these eyes subsequently. So when the concept of slit came in, we actually, the first patient that we did slit was actually an allo slit, because we wanted a proof of concept before we touch a normal patient to see for ourselves how it works. So the first patient that we did slit was an allo slit, where what our idea was to apply a source of epithelium on the amniotic so it epithelizes faster. And generally, whatever be the grade of injury, if there is no line plaque, if your amniotic sticks well, if your slit bit stays on the surface, in 2 to 3 weeks, the surface epithelizes. And if the surface epithelizes in two or 3 weeks, then your underlying cornea doesn't scar. This surface will fail because we are not giving systemic immunosuppression to these patients. You are putting cells in a very hot, inflamed eye, but it serves the purpose by getting a epithelium on. It conjunctivalizes, fine, absolutely fine. 6 months later, you can peel it off just like you peel an amniotic in a grade 3 or a grade 4 chemical injury where you have just done an amniotic and it has conjunctivalized. It peels off with an underlying clear cornea, you go in and do an autogenic slit. So the idea of allo slit is to epithelize the surface faster if there is a significant conjunctival involvement. So if it is like Dua's classification, there is 50 or 70% conjunctival defect and more than 6 cloacas, 8 cloacas of limbal involvement of your cornea, then yes, an allo slit. But if your conjunctiva is only 20% and we are talking about a grade 6 with more of corneal involvement, you probably don't need an allo slit. But most of the times, if you're looking at a lime burn or you're looking at a grade 5 or a grade 6, what we see, at least in a tertiary care center, is almost from a fornix to fornix defect as far as the ocular surface is concerned. So in those cases, allo slit helps us achieve the objective of getting an epithelium on in a 3-week period and saves the cornea, and we can always live to fight another day subsequently as far as vision is concerned.
Thank you, Bhaskar sir.
So,
Sir, and
one more point to add, Sumit. If you don't have allogenic slit, you can do SOMET, right? So you can just take a piece of mucosa, divide it into multiple pieces, and spread it over the corneal surface, and same apply fibrin glue like that.
The other thing in terms of when we would want it as early, you don't need fresh, but even 4 days, 5 days tissue is fine. The earlier the cornea, the better, because the cells will survive. But even for a keratolimbal allograft, there is no kind of regulation that you have to do it within 2 days or 3 days. So even an 8 or a 10 days, because sometimes even in a tertiary care, we don't have tissues which have just come 1 day back. We might be using a tissue for a transplant and we have the rim. So we just use the limbus in the rim. Only thing is you'll have to make sure that the rim has limbal tissue, because sometimes the eye banks prepare tissue in such a way that they scrape off the entire limbus. Then it becomes a bit of a challenge.
Thank you, sir.
This SOMET, Ganesh, just a minute. I just wanted to ask, sir, the SOMET is generally, are they using for bilateral limbal stem cell deficiency nowadays? Your any experience with that?
A SOMET is not going to really have a clear cornea like usually we see in SLED, allogenic SLED. So yes, bilateral limbal stem cell deficiency, the choice is always going to be living related or allogenic SLED with immunosuppression. And SOMET is not going to be a choice of surgery for visual rehabilitation as such, but whenever we want the surface to epithelize and patient to have ambulatory vision and we don't have any source of slit, we can consider always SOMET. But yes, it is not going to give that clearer cornea. Why I mentioned SOMET here is because you said that if you don't have the tissue, what will you do? So you can always use use a piece of mucosa and make the surface vascularized. The point is from somewhere we should get the epithelium.
Ganesh, over to Ganesh.
Yeah, thank you very much for a nice discussion on the case. Now we are moving to next case by Dr. Pranali. Over to you, Pranali.
Thank you, sir. Good evening, everyone. I'm going to present a case presentation. So, chief complaint, a 14-year-old female patient brought by the parents with the chief complaints of constant rubbing in the eye since 1 year, redness in the eye since 1 year, and diminution of vision since 1 year.
Pranali, can you try full screen?
Yes, sir.
Okay.
History of the presenting illness. Patient was apparently all right 1 year back when she developed foreign body sensation in the eyes, which was gradual in onset and progressive in nature, for which patient constantly rubbed her eyes. Patient also complained of redness and itching in the eyes, which was gradual in onset and progressive in nature, fluctuating with the seasons. She also developed diminution of vision in the both eyes, which was gradual in onset and along with the above symptoms. In the negative history, there was no history of trauma to the eyes, foreign body injection in the eyes, photophobia, yellow sticky discharge, pets in the house. There is no history of change in household or school, fever, contact lens use, or any ocular surgery. In past history, there is no history of similar complaints in the past. In treatment history, patient gave history of instilling unknown eye drops for the same, and symptoms get relieved on and off by the same. In systemic history, there is no history of allergies or no history of fever or cough. In family history, there is no history of similar complaints in the family or no history of any blinding diseases. In personal history, bowel, bladder, sleep, and appetite was normal. On general examination, patient was conscious, well oriented with time, place, and person, and vitals were stable. And on systemic examination, CVS, CNS, RS, and per abdomen was within the normal limit. On ocular examination, head posture was normal, facial symmetry was normal, eye alignment was normal, and extraocular movement was full and free in all direction of the gazes. On ocular examination, visual acuity in right eye was 6 by 18, and with pinhole it improved to 6 by 9, and best corrected visual acuity was with -2 diopter sphere and -2 diopter cylinder. It was in 180-degree axis, it was 6 by 6, and in left eye, vision was 6 by 12, improved to 6 by 9 with pinhole, and with -2.5 diopter sphere in 170-degree axis, it was 6 by 6. On slit lamp examination, I'll describe right eye first. Eyebrows, eyelids were normal, and eyelashes were matted with discharge. Conjunctiva, bulbar conjunctiva, congestion were present. Palpebral conjunctiva, giant papilla was seen, and in fornix there were no foreign body. And on limbus, there were Harnatranta spots from 9 to 2 o'clock position. Cornea, anterior chamber, iris, pupil lens in the right eye was within normal limit. IOP was 17.3, and there was no regurgitation on pressure on the sac. In the left eye, eyebrow and eyelid was in normal. Eyelashes matted with discharge. Conjunctiva congestion was present. Giant papillae were seen on palpebral conjunctiva, and there was no foreign body in the fornix. On limbus, there was Hornatronta spot from 9 to 2 o'clock position. And in left eye also, cornea, anterior chamber, iris, pupil, and lens was within normal limit. IOP was 17.3, and there was no regurgitation on pressure. This is the picture of the right and left eye showing giant papillae in the palpebral conjunctiva and ornate frontal spots from 9 to 2 o'clock position. And on fundus examination, it was normal on direct ophthalmoscopy. So my provisional diagnosis is both eye Werner keratoconjunctivitis with both eye compound myopic astigmatism. Thank you.
Pranali, stop sharing the screen. And Dr. Kulkarni sir, you can ask questions regarding case.
Yeah. So you mean to say that the patient first time presented at the age of 14 years and she never had this symptom before?
Yes, sir. She didn't had the similar complaints in the past, but she's having complaints for 1 year for the same, and she took drops for that, and on and off symptoms were present for that.
Did the patient
For
present
1 year.
with the medicines? Whatever medicine she was using, did the patient present with the medicines?
No, sir.
So they were not known, but she gave a history
Yes,
that they were relieved by the symptoms were relieved by the medicines. So do
Yes,
you
sir.
think that the patient must have received steroids?
Yes, sir. Patient must have received steroid for because of that on and off symptoms with them.
Okay. If I want to ask you one more clinical test which you would like to do, especially looking at the corneal curvatures. Patient has already started developing minus cylinder at 180. So have you done the keratometry measurement of this patient if you don't have access to topography?
Yes, sir. Keratometry was done, and we found that it was compound myopic astigmatism.
That is, you're talking about refraction. So K1,
Yes,
K2 need to be documented. This is very important.
Yes.
And intraocular pressure you already have seen because the child may
Yes,
be a
sir.
steroid responder. So this is clinically there is no doubt that this is vernal keratoconjunctivitis. You can have palpebral and limbal form both together or in isolation, either limbal or a palpebral form. So, what was the treatment started in this child?
Sir, first of all, we ask the patient to do patient to take care of to reduce to avoid allergens and lubrication, and then mast cells and in mast cell inhibitors and antihistaminics were started, and then steroids were started.
Which
And
is the choice of your steroid? With this clinical picture, what will you prefer?
Sir, will prefer potent steroids in the patient. As papillae were giant papillae patient present with the giant papillae, and prednisolone acetate 1% was started with the tapering dose.
Okay. So how long did it take for the child to respond to the treatment? What is your schedule when you start steroids, and when do you check the pressure after starting steroids?
Sir, we started patient on steroid, and then after every 2 week we asked the patient to do follow up, and in follow up we measured the intraocular pressure and other examinations also for the patient.
So there are different types of ocular allergy. You gave the history that the patient had this with seasonal exacerbation, and
Yes,
if you say that this is vernal keratoconjunctivitis, which is the type of the allergic reaction involved, which type of cell the immune cell is primarily responsible, whether it is humoral immunity or the T cell mediated immunity.
Sir, actually both immunity plays a role in the symptoms, but Th2 it is mostly a Th2 mediated cell reaction, type 4 hypersensitivity reaction.
And how it is different from atopic keratoconjunctivitis, which is also a T cell mediated inflammation. Clinically, what is the difference?
Sir, atopic conjunctivitis, patient will give a history of any other allergies also, and as this patient doesn't have any history of allergies, we can differentiate it from the atopic conjunctivitis.
Any difference in clinical picture, involvement of the lid margin, especially the anterior lid margin and the skin?
Yes, sir. In atopic conjunctivitis, we'll see involvement of the lid margin and the skin of the lid.
So most important thing is the patient should not rub the eyes. You have to control
Yes,
the
sir.
inflammation fast, and if the papillae they do not come down with the treatment, what are the likely complications of this type of allergy? What can happen to the corneal epithelium? What can happen to the limbus?
Sir, by constant rubbing of the eyes and the giant papilla are present on the palpebral conjunctiva, the constant erosion of the epithelium may be seen, and there may be uh, uh, because of that there may be erosion of the epithelium, and the ulcer may be formed, and as punctate epithelial erosion, it may grow into coarse epithelial erosions also. So we have to be cautious about that. Patient shouldn't rub his or her eyes.
Is there any specific name which is used to describe this ulcer?
Shield ulcer or Togby ulcer.
So before starting treatment for shield ulcer, would you like to scrape and rule out microbial infection when you label it as ulcer before you actually start the steroids? If the patient presents with ulcer with giant papillae, will you scrape the ulcer, rule out the infection, and then start steroids? What will be your protocol?
Sir, usually scraping is not mandated in this type of ulcers, because it is mostly because of the allergies, allergic condition it is caused. So we can start patient on steroids in this type of
So
ulcers.
is there any point against scraping? You cannot assume that this is papillae-induced shield ulcer because of the pressure effect of the papillae, even if it is in the central or the superior half of the cornea, even if the classical picture of a shield-like presentation. Unless proved otherwise, only erosion of epithelium, when the damage is restricted to epithelium, it's a different scenario. But when you call it as ulcer by definition is breach in the epithelium with necrosis of underlying stromal tissue. So if you have an ulcer, you must rule out infection, because if you give these patients with strong steroids that too very frequently, you can land up in trouble. So whenever you are dealing with this, always rule out infection. You don't lose anything by scraping. Okay.
Yes.
Any other treatment apart from medicines you would consider?
Sir, basic like lead hygiene, cold compressions is given to the asked to the patient to follow, and then anti-allergic medications like antihistaminics, mast cell inhibitors are also given, and then cyclosporine A. If it is not responding to steroid, then cyclosporine A and tacrolimus is also can also start in a severe condition.
So any other steroid you would consider apart from prednisolone acetate? What would be your choice? You want the inflammation. You see, you want this drug to act on the surface. Okay, prednisolone being an acetate ester, it will penetrate the eye very faster, so it won't remain on the surface for a longer period of time. Any acetate ester is going to enter the eye faster, so you need an alcohol derivative. So fluorometholone is a good choice. Yeah, and beware that dexamethasone and betamethasone, they have increased propensity to cause steroid-induced side effects, especially the posterior subcapsular cataract and glaucoma. When lotiretinol at various concentration, it does have a good effect. So the basic principles of control of inflammation are: you have to hit hard at the first go, and then reduce the dose, and maybe change the molecule to maintain the disease. But most important follow-up, you have to look for changing in the corneal curvature, and special emphasis is always given on intraocular pressure. So always have a look at the contours. And you have to emphasize also the importance of each rub, each cycle. Because of itching, there is rubbing, and because of rubbing, there is further itching. So we need to break this cycle anyhow. The best way to break this cycle is the cold compression.
Thank you, sir. Bhaskar sir, any comments on case?
Yeah. So in terms of even your clinical management and from your exam point of view, it's important to know the grading. So if you're talking about papillae, you need to know the grading of papillae. If you're talking about shield ulcer, you need to know the grading of shield ulcer. There are 3 types of shield ulcer, because not just from the exam point of view, because if you have a grade 2 or a grade 3 where there's an elevated plaque, just putting a bandage lens on top and putting steroids will not work. You will have to remove the plaque for the epithelium to heal as such. So in a chemical injury, there are certain points. In a allergic VKC, there are certain things. All your findings have a grading. Again, in terms of management, Dr. Nikhil Gokhale's paper and algorithm is there, where he has graded it into mild, moderate, severe, and sight-threatening. So you need to categorize your findings based on that, because that gives you a logical reason as to what you're going to offer the patient and when you want to shift to the next level. In terms of what are the other options that you have, obviously you have the option of giving a supratarsal injection of steroid. If it is not responding, you have the option of cryo. You have the option of putting the patient on systemic medications. If topical steroids alone are not worsening, we would probably give a course of systemic steroids first. But if the patient requires a repeat episodes of systemic steroids and the papillae are causing significant erosions on the cornea, then you would have to take a decision whether you want to go for an escalation in the medicine in terms of a systemic immunosuppression, or to go ahead with a surgical excision of the papillae. Fortunately for us, post tacrolimus era, the number of patients whom we have to do this kind of interventions have reduced. Between cyclosporine and tacrolimus, at least in my personal experience, I feel tacrolimus works a little bit better than cyclosporine, even though the experience with cyclosporine earlier was with the 2% cyclosporine, which was very toxic for the patients to use to, and the 0.05 which was available was not sufficient in terms of concentration. The newer 0.1s with a nanomicellar technology are supposedly effective, but I have not used it in a clinical study to claim the same. But tacrolimus to a large extent is tolerated. Even if it is not tolerated, you can ask patients to apply it on the lids, so that transdermal absorption also helps in controlling the disease activity as such. And most of them, almost I would say about 80 to 90% of them, tend to kind of get under control with tacrolimus. What was surprising in your patient was somebody at 14, where I would expect hormonal changes to set in, coming with allergy only at a 1-year history. I would probably think she had it or there has been definitely a change of position, a change of location, or something of that sort. And the other thing that we have seen, there is a subset of patients whom we call as adult onset VKCs. But in an adult onset VKC, it is important to rule out any immunodeficiency state. Because if there is an immunodeficiency state which is, say, affecting the T cell, then the body compensates and has more of a B cell response, which will again show up as an increased allergic response in the eye as such. And we had a case report which we published in IGO showing a Th1 to Th2 shift in a patient of HIV. So if you're seeing, say, not this particular case, but if you're seeing a laborer kind of a patient who's coming for the first time and having significant VKC and responding only to steroids, not settling down, that would probably be because those are patients where you are anyway suspecting them to have issues with their systemic condition. So it might make sense to actually get an HIV test done in the sitting of a young manual laborer or a migrant who's staying in a place and has severe allergic conjunctivitis with no prior history of allergic eye disease in childhood, because that subset having a pure adult onset VKC is very, very low, even in a tertiary care center.
Swapnil sir,
I think,
any systemic workup?
Sorry.
Hello.
Yeah.
Yes, sir. Swapnil sir, any systemic workup is helpful in VKC, such as IG levels and allergy test?
Yeah, see, rather than IG levels, I don't think it is very helpful. But yes, in some patients where there are also systemic symptoms like, seasonal allergies, sneezing, and, asthma, you can always get the allergy profile done, allergy testing done, and look for the offending allergen. And also these days, they provide excellent desensitization treatment. And I'll not say that it will help to, relieve the symptoms completely. But yes, it's an adjuvant treatment which might reduce the use of drops or, kind of systemic medications. Like in severe VKC, sometimes even I use where it is not getting controlled by anything else. We also use oral cyclosporine or all these oral immunosuppressants. And in those cases, I usually get the allergy testing done and try to find out the offending allergen, and also try to put them on desensitization treatment as a adjuvant. So that at some point of time I would be able to reduce my oral cyclosporine. So there is a role of desensitization, but I am not sure about IG levels. It would be helpful or not.
IG levels in VKC doesn't make much of a difference. The desensitization, again, at this point of time, people do it only if they have a significant systemic allergy. So if they have it with respect to significant dermatitis, or they have it with respect to significant asthma, then for a pure ocular allergy, it's still not accepted as a standard of care, even though we are kind of trying to explore the avenues to see if it can be of benefit as far as ocular allergy is concerned.
So how many times you give systemic immunomodulators in your practice, and especially in what age group?
Swapnil,
yeah, sir, your question is how systemic immunomodulation, right?
Yeah.
So whenever I feel that patient is steroid dependent, right, there is vision threatening complication like the limbus is getting involved, and we feel that the patient is going to land up in LSCD, and the vision, that's a severe complication. So whenever I feel that one is steroid dependent, it's causing steroids are causing long-term complications, not responding to tacrolimus or oral topical cyclosporine, then I request my rheumatologist to start on oral cyclosporine. And trust me, if patient can afford it, it's very well tolerated drug. It's least toxic drug. I have children who are on oral cyclosporine since last 9 to 10 years now, and they are doing so well. The moment I take it out, they start relapsing, and they start having severe symptoms again. So like from youngest I have given is like 6 years old, oral cyclosporine. And from that, but you just have to keep on monitoring serum potassium, blood pressure, and all those side effects of the oral cyclosporine. But it's a safer drug.
So I mean, it's not very common. Probably maybe 1 or 2 in a year that we would probably give systemic immunomodulators. At SN, I mean, there are 2 issues here. One, if you are basically dealing with the papillae, which is causing a corneal erosion, and that is what is causing your sight-threatening thing, then before going to systemic immunosuppression, at SN, we would look at doing a shave excision and replacing the tarsal conjunctiva with a mucous membrane graft, which we have had a reasonable success. If it is more of a limbal variant, which is just recurring and it is not getting settled with the moment you are removing topical steroids with topical immunosuppression, also it's not getting settled, then that would probably be the indication where we would opt for systemic immunosuppression rather than a local papillae excision as such. The third would be a patient with AKC. AKC, we know systemic cyclosporin has a definitive role. We've looked at tacrolimus, which is basically almost the same group, but the side effect profile seems to be a little bit better than cyclosporin as such. So we've started using that as a systemic.
Very expensive drug, but
expensive, yeah. So in certain select cases, we have tried to use that as a thing, because we started with cyclosporin. A couple of patients came with gingival hypertrophy, then we had to kind of shift over. So the important thing is, when you're dealing with any of these medications, even though we can read up and give it, it is safer to, especially if you're dealing with a pediatric patient, to keep a pediatric rheumatologist or somebody who deals, or a dermatologist or a chest physician who deals with these medications day in, day out, rather than try to manage the doses. We can always convey our requirements to them, and they can take the call on initiating them and maintaining the dosage appropriately without having the side effects.
What I follow is always let rheumatologist write for you and don't write it yourself.
But yes.
Yeah, so legally also you say.
The field has increased so much. We can't be aware of all side effects of all medications, and in a pediatric patient, the possibility of litigations and all things are much higher. So it's always safer.
So one more clinical sign, Dr. Pranali, you missed is one is a classical sign of VKC is limbal pigment dispersion. So yeah, so that is one of a very unique sign to VKC, which can differentiate, between other allergies and VKC, and it is described in a separate paper.
Yeah, Dr. SKR, I was a part of the paper. It was the first paper that I had written with him when I joined my fellowship. So that's something which is important. Also, it's important to, when you're looking at the papillae, to look at the staining. So just like you see limbal papillae, but unless there is the staining or the stippling on the surface, or you see the white dots, it doesn't indicate activity. Similarly, even on the tarsal papillae, if you are seeing the papillae surface is smooth, there is no fluorescein staining, then it's an inactive papillae. But if you're seeing a staining on the surface of the papillae, that indicates activity as such. So that kind of tells you whether you need to still continue your topical steroids, or you need to hike up your steroids, or you need to add on tacrolimus. As far as the other mast cell stabilizers are concerned, in the kind of VKCs that we see mostly in terms of institutes, they are probably not really helping us much, except if you have a very clear seasonal variation. Like in this patient, if the history is very clear that there is a seasonal exacerbation, then prior to that season, we can start them on something like Romalfort or some of these dual acting agents to kind of control it as such. But in a general perennial VKC that we see in an institute, even though we do prescribe it, it's not that we don't prescribe it, but I feel it's more like our psychological feeling that we feel it makes a difference, rather than it actually making a huge difference. Because in these cases, you have to give steroids, but you have to make sure that you give it for the least time possible, so that the side effects are limited.
Yeah, there are a lot of patients who are already using olopatadine or something like that, but they still have exacerbations even when they're using that. So in my experience, the 4% sodium chromoglycate so far has worked the best, the chromal 4, because initially the chromal 2% was available, but the 4% shows some promise. Yeah, that's true. And this pigmentation is not only restricted to limbus. I mean, you just pull the lower lid down, you will see a lot of pigment in the
it's dispersion.
Yeah, dispersion.
Thank you everyone for a nice discussion on this case, and now I am sharing two dilemma cases for a discussion. Everyone is seeing the screen, or
just make it full screen. It's very much visible.
Okay. First case is a case of a 65-year-old male operated 11 years back with other hospital, developed recurrence 4 years back. Then again, he was operated by a cornea surgeon, and mitomycin C was used. Now, this time he came with a second recurrence and presented to me with this picture. And this lesion is actually hampering the vision, and also simuliferon is there. So, what is the take of panelists and seniors about management of this type of a second recurrence?
So Bhaskar, you would like to comment?
Yeah, sure. So basically, if there is no other predisposing cause, it probably boils down to the fact that when you operate a pterygium and you are the most important thing in the perioperative period is to avoid inflammation. If you have a recurring inflammation, it will kind of creep up. And more than mitomycin C, the success rate with a conjunctival autograft is much better. This is a large area, so you might want to form the fornix there, put a bit of amniotic on to kind of cover the area, and you will have to cover the limbal border from almost that 6 clock hours. So if you feel that you can't get such a long strip of conjunctiva, you can take a broad strip, cut it into two, or cut it like a in the snippet in the center, so you can kind of expand it like an L and put it around the limbus. Your barrier around the limbus is important so that you prevent the conjunctiva from growing in, because the tissue that you put, you are basically giving time for the corneal epithelium on both the sides to kind of form the barrier. And if this tissue that you're putting as a free graft has to first get its vasculature, and then the cells will multiply and start moving on. So it acts as a barrier, allowing the cornea, the corneal epithelium, the time to migrate and cover the barrier. If you're putting just a sliding graft kind of a thing, the recurrence is still higher because it's already a vascularized pedicle which is coming there. So here I would probably go ahead. The only good thing here is it is not very fleshy. It's not very vascularized. So I would only thing I would want to get is an OCT done to check the thickness of the cornea underlying that area. And if the thickness in the underlying area is okay, you can go ahead with excising it, putting an amniotic and putting a conjunctival graft on that side.
Also, and additionally, Ganesh, you can use small patch of MMG on the area of the bare area of the lid, which will be created subsequently. So you can just cover with MMG so that that area will be taken care of with, because conjunctival autograft is unlikely to take care of the inside surface of the tarsal surface of the lid, which appears to be
So when you're excising the conjunctiva, you can push the conjunctiva, which is of the pterygium, the epithelium, you can push it towards the fornix to form your fornix with the fornix forming suture. So basic principle is for a pterygium, for a surface reconstruction is simple. If you can have epithelium on both sides, that's the best. So it will not stick. And the area that has to epithelize has to be the smallest possible. So here you put an amniotic here, either you put an MMG on the tarsal surface, or you reflect the conjunctiva back to kind of create a fornix. You put the amniotic, and the rest of the bare area of the amniotic, you're putting the conjunctival autograft from the superior or the temporal area. So you leave as less an area for it to epithelize. Start with a good dose of topical steroids in the post-operative period, and this should settle down without an issue with recurrence.
Thank you, sir.
Also, in some cases, you can give subconjunctival 5-fluorouracil, which I usually do for recurrent pterygiums. So you can give every 15 days, 4-5 injections, let the vascularity and fibrovascular tissue come down, and then you can operate. That will also help you to reduce the recurrence.
5-FU has been known even in early recurrences to kind of give it to kind of control it. And if it's a very fleshy thing, then it makes sense to kind of give it to at least reduce the severity of your recurrence, if at all you get one also. And it makes your surgical field and plane also a lot more easier.
In fact, I use 5-fluorouracil in young patients with highly vascular pterygium, highly fleshy pterygium. So I use like 3 doses of 5-fluorouracil before surgery, like for 45 days, 3 doses, and then I operate after 15 days. So that makes a job much easier. The tissue is much less fleshy, and you can reduce the recurrence as well.
So what is your dose and the site of injection and the volume?
The same injection which comes in the vial, sir, you don't need to dilute it. You can inject it subconjunctivally.
The site?
Yeah, site, it's in the pterygium tissue, sir.
Yeah, that's important.
0.1 cc generally at every visit if you are injecting.
It has to go in the pterygium tissue because it needs to act below the elastosis where the inflammation is setting down and it's causing the fibrovascular tissue formation.
Yeah.
Thank you, sir. Moving on to next case. So next case is a case of a bilateral limbal stem cell deficiency. 25-year-old boy with a recurrent episode of weakness in the past. Right eye is PL positive, PR accurate, and left eye is the vision of C-meter, and Shermans are normal for this patient. Now I want to ask management for right eye and anything can be done for saving the eye cornea of the left eye.
OCT has been done?
No, not yet.
So, yeah, Dr. Bhaskar, you want to comment,
So
please?
basically, I mean, there is still a little bit of inflammation if you see the picture on the right. So I would
Yeah.
probably be looking at to control the allergy. I would already need systemic immunosuppression. If I'm needing systemic immunosuppression to control the allergy, then I might as well consider an allogenic slit for the other eye for vision. The eye where the cornea is centrally clear, just putting systemic immunosuppression might improve it a little bit, and then you can give the patient a pros contact lens to improve the vision in the left eye as such. If nothing works and it fails and the patient cannot afford immunosuppression and things like that, you do have the option of keratoprosthesis, but that's something that we would reserve as the last option, only if everything else. Kpro will give good vision, but you're talking about a 20-year-old patient. You are not sure the Kpro is going to last his entire lifetime with the inherent risks in a Kpro. So don't jump into a keratoprosthesis in this group where there is inflammation. So in a group where you anyway need systemic immunosuppression to control the disease, stem cell plays the immunosuppression will work both for the disease, it will work for the stem cell therapy that you're doing. So it's like a win-win situation for you.
Yes, thank you.
So
Thank you very much.
one question, sorry to interrupt. One question we had got from PGs. Does the management changes if the chemical injury is acidic or alkali? It was questioned by Dr. Akash. Swapnil sir, any lights on that?
I would say the only difference I have noted is like Dr. Bhaskar said, you have to look at the IOP. So intraocular pressure tend to rise in acid injuries more compared to the Chuna injuries, number one. Number two, Dr. Bhaskar already mentioned that you have to look for the cicatricial changes setting in acid injury, because usually they tend to develop cicatricial ectropion and that causes a lot of exposure. And you have to look for exposure in these patients. In acute stage, you can obviously do tarsorrhaphy. Recently, we had one patient where the acid injury came very early and we did a biological graft just below the lid. We involved the general surgeon and did it, and it worked quite well. So in acid injuries, you really have to keep eye on the facial injuries as well, so that cicatricial entropion should not develop. Yeah. Other than that, the management differs a lot, because in Chuna injury, you have to explore the phonics and everything to get those flecks out. Acid injury, most of the times you wash the eye properly and you would be able to get rid of the acid. And then, yes, acid injuries are less dangerous than alkali injuries.
Acids don't penetrate as well as much as alkali, according to the basic science principle. So your burns are more superficial to that extent. But obviously, if the pH of the acid is more, the effect is more because of the changes on the lids and adnexa, which causes more of a problem. If you have an adult with a Lyme injury, it is like a plaster of Paris kind of a thing that can have on the face, that can also cause a bit of burn, but that doesn't cause that much amount of lid changes, unlike an acid. It causes more of cornea and intraocular penetration related issues. So in that sense, your lid changes are more with acid, like Swapnil has said. Your medical measures, your aim to epithelialize the surface in terms of your algorithm is probably the same. But the important thing is, remember what are the things that you need to look for in a chemical injury: epithelium, IOP, lids. And once you are sure that these are the three things that you have to make sure that it epithelializes and the offending agent has to be removed, then you're in the right track. And if any of these parameters worsen, tells you need to intervene. So for IOP might be low. If the IOP is low, also is a problem. That means it's a ciliary shutdown. You might have to give systemic steroids. Similarly, sometimes if you have a chemical injury and you see an absolutely white eye with chemical injury, it is actually a signal of disaster, because the entire vasculature has got burnt out. So we do get calls and photos that, Acha, eye is theek hai, red nahi hai, patient is quiet, patient is comfortable because the nerves have all got burnt. So patient is not complaining, but the eye is deepithelized and white, which is a recipe for disaster unless you intervene. So you will always stain, and check the epithelial defect status at every visit. You will always check the pressure at every visit, if not with a device, at least with your finger tension to know where you are going to with respect to it. And every visit, you will document the exposure of the globe if there is any exposure. These would be the three main take-home messages as far as any chemical injury is concerned, apart from the most important thing of removing the offending agent.
Usually severe acid injuries land up with bad glaucoma, and you have to plan balls quite early. They also get kind of a complicated cataract and glaucoma, so you really have to watch those acid injuries for that.
Sir, one last question. Many of the times, even after doing everything, even after your stem cell transplant, sometimes you don't achieve the cornea clarity and you have to go ahead with the corneal transplant. But most of these cases come with the persistent epithelial defect even post-transplant, because the limbus is not that great. So how do you manage, because this will land up into the early melting. So how do you manage those persistent epithelial defect post-keratoplasty?
First, do nice tarsorrhaphy.
One is do tarsorrhaphy in the postoperative period, but what is more important here is to reduce the need for us to do keratoplasty in an acute chemical injury is by getting the epithelium on ASAP. If you are able to get the epithelium on the surface in a month, your need to do transplants will come down significantly. In our data also, what we published, the number of LKs in the previous series between 2008 to 2015, almost all of them required LK or a PK at some point of time because the cornea underlying was scarred. The moment we started doing an allogenic slit for very severe, and it's not that it's not that alloslit doesn't fail. Depending on the severity, it will also fail. But at least to the extent that if you are able to get the epithelium on the surface in a month's time, an autoslit in an eye which doesn't require a transplant survives better as compared to an eye where you have to combine it or stage a transplant. Obviously, with the graft-host junction, the other thing for a PED would be the graft-host junction. If your graft-host junction is a little bit irregular, it will preclude the epithelium from growing across the bump and reaching it. So it's a neurotrophic cornea. It's a stressed out limbus. There is a little bit of an exposure. So you would have to be more proactive in these eyes. Tarsorrhaphies, amniotics, maybe autoserum tears will play a role in the chronic phase of the disease to maintain an epithelium rather than in the acute phase of the disease. Once you have done a PK, you have to try to give it all nourishment that is possible to maintain the epithelium integrity as best as possible.
Again, to repeat, epithelium means any epithelium, corneal or conjunctival, we are okay with. Number one. Number two, you can even try pedicle conjunctival flaps. If it is not at all healing, you can just take out the flap, make it attached somewhere, keep it attached somewhere and take it on through the persistent epithelial defect and do tarsorrhaphy, it will heal.
So no need to add stem cells again at this point in time.
So don't use autologous stem cells to make the persistent epithelial defect heal. Any acute condition, do not use autologous slit. Please reserve that precious stem cell tissue of the other eye for the last resort, as final resort to settle the corneal epithelium and for the visual rehabilitation. Do not use autologous tissue for healing of the persistent epithelial defects in acute chemical injury. That should not be the message. Allogenic slit is a different ball game. Autologous slit, we have a limited resource. We cannot touch the eye again and again. So autologous slit should be done only after the surface is settled, less inflamed, and now you are pretty sure that when you do autologous slit, the result is going to be very good.
The important thing here is to identify
cause of
the surface is breaking down. So if the surface is breaking down because of exposure, obviously you need to address that. If the surface is breaking down because of dryness, you need to address that. If the surface is breaking down because the graft-host junction is insufficient, is inappropriate, you need to address that. Then it also needs to depend on whether your graft that is there with a defect is surviving or it is a failed graft. If it is a failed graft, I would be less aggressive. I might even just do a cyanocolate glue and a contact lens and allow it to stabilize, because I know I have to do a regraft. And before the regraft, if this primary defect happened because of a deficiency of stem cells in terms of a limbal deficiency, which was preventing it from healing well, then I would want to do an autogenic SLET or a CLAU along with my PK, or stage the procedure, do a SLET first and then follow it up with a PK or something of that sort, based on the thickness of the underlying cornea. So it is not one fixed solution that हाँ defect है तो stem cell करना है. It's not like that. You first need to understand why it is happening and logically do the least invasive procedure first before you go on. And like Swapnil said, autologous tissue, you have a limited ability to take. So you don't want to waste it in these situations where you can get away with something else. You will use it only once the eye is absolutely quiet and you are doing something from a vision point of view. Use it at that point of time to give it the best outcome.
Thank you, sir. I would like to hand over the session to Atul sir. Over to you, sir.
Thank you, sir. Good evening, all. As you know, this MOS PG activity this month is for ocular surface. And today we have a very nice discussion, right from the PG levels to the extreme for all the members also. Even for the PGs, the discussion went from the to the depth of the chemical injuries and the VKC cases. I must thank, we are lucky to enough to have today as a panelist, Dr. Bhaskar Srinivasan sir and our own Swapnil. They thank you very much for giving enlighten us about the subject. We have as a mentor, Dr. Ajay, my batchmate and our savior in our area. For any complicated cornea case, we feel Ajay is there, so we feel secured. And Dr. Gurudasani is here. Thank you, sir. You had moderated the show very nicely. Both Dr. Pranali and Piyush, you presented very elegantly. And thank you all the PGs and all the members who attend the programs. So the next Thursday we'll have another PG program on the same ocular surface. See you then again. Thank you.
Thank you. It was a pleasure.
Thank you, Sumit. Not to forget, Sumit is the backbone of all PG programs. So it's yeah. Thank you.
Thank you.
Thank you, everyone.
Yeah.
Thank you. Thank you very much.
Thank you all.